Matt, thank you very much for having me. Yeah, I really appreciate the opportunity, and obviously, it's a tremendous honor to come to Stanford University and have the opportunity to talk. And so, Brian, thank you very much for inviting me. I mean, Stanford is an absolutely amazing place. I love walking around when I come here, seeing, like, going to the undergraduate campus and just recognizing all the tremendous contributions to technology and society. But as I was walking around campus the other day, I realized that there might be no greater contribution than the bicycle graveyards. Never realized these existed or anything. I actually saw a number of Schwinn Stingrays from the early 70s with the banana seats on them, but they were definitely all over the place. But it's nice to see that people are respecting the environment by riding their bikes all over the place, and I had a great chance to go up to the dish and visit there. As I mentioned earlier, I want to thank Brian and everyone else, your division chiefs, the residents, the vice chairs, and everything for giving me this great opportunity. Anytime I go to a place to lecture, I do like to acknowledge those people from MGH. Some of these, I think the one that I've probably known the longest is probably Anita down there in the lower corner, and but obviously Al's been a good friend. Did his fellowship there. Matt, Tony, and Sam. I just realized that Sam's down here, and obviously Sarah too, and many others. So again, I really appreciate this. I was a resident at 1.2, and you can see there I'm on the left side of the screen. On the right-hand side is Warren Zapel, and Warren was really instrumental in getting us to change the way we try and prevent substance use disorders and how we actually manage challenges that we have with our faculty members. So I have no disclosures related to this topic. Just as Matt mentioned earlier, I have written and spoken on many topics that do at times collide and come together with substance use disorders, including death by suicide and disabilities among healthcare providers. And my own family has been impacted by all of these. I don't think any of us are actually immune to these conditions. Our goals and objectives, we're going to cite the incidence and causes of substance use disorders in anesthesiologists. It's very unclear. We're going to differentiate some of our means to control substances in the perioperative arena. We are going to talk a little bit about the benefits and downsides of drug testing, and there are some downsides. And we're going to explore the concept of interventions when we are concerned that a colleague may be impaired by some sort of condition. And in all honesty, our experience is very rarely it is a substance use disorder. But that doesn't mean that we don't have something that we need to address in a compassionate manner. So you can see here, this is my brother, Andy. Andy very much looks like the Revenant and Leonardo DiCaprio in that movie. And there's Andy sitting with his two nieces, Annabelle and Caitlin, my daughters. And Andy loved nothing more than coming to Boston and spending the Christmas holidays with our families. And Andy absolutely loved his nieces. But unfortunately, in 2017, Andy died of a long-term chronic disease, which was substance use disorder. And, I knew the minute I got the call, it's 2 a.m, just said Dad. And I knew what had happened. And, Andy tried to fight this disease his entire life, and he could just never control it. But by the end, we actually felt that he had it under control. We felt he was doing well. And the thing I thank God the most for is Andy was never estranged from the family. He was always in touch with the family. He was always visiting. And again, he loved coming to Boston. But he never achieved a cure for this disease. So there's a high incidence of substance use disorders in society and healthcare providers. Our lifespan may actually be reduced when you compare us to internists, and this is largely related to substance use disorders, death by suicide, and other external causes of death. And unfortunately, everything we've done in the past just doesn't seem to have reduced the incidence. And colleague intervention is a very critical step in recovery and management of any sort of problem that we're having. So these are questions that we need to ask, especially when we're talking about screening, screening test. Do we have a problem? Does anything work? Does it pay to fight the problem? And if we're talking about drug screening, is it effective? Is it easy to beat? Is it dangerous? But what else also needs to be done? So do we have a problem? The answer is absolutely yes. The problem is we're not sure why. We know that the drug-related death is higher than guns and higher than motor vehicle accidents. When I started to give these talks back in around 2003, 21 years ago, overdose deaths were 20,000. A very, very small number. But in 2022, 105,000 American citizens died of some sort of overdose. And even though we see a little bit of a decrease there from the prior year, deaths due to fentanyl and psychostimulants continue to increase. And why? In the early 1980s, this concept of, if you're having pain, you don't get addicted came out. Boy, and that was just, that a lot of these companies were off to the races with that statement. It's almost free reign to do what you want. And then when I was a resident, I started in 1997 after several years in the military. One thing I was taught, word for word, is the problem is we do not give out enough opioids. Now, I did primary care for a number of years in the military. And man, if you came to me and you had shrapnel or something in you, or you hurt yourself down at the motor pool, if you were really hurt, you might get 8 Tylenol number 3s in a little tiny baggie. But that was it. I was scared of opioids, and all of a sudden I come back into an environment where I'm writing these crazy level of prescriptions. And it was kind of became a joke among the anesthesia residents that, oh yeah, did you get the 12 o'clock call last night from a person wanting a refill on opioids? And, we started to, we all were kind of joked about as among being an annoyance, but didn't really start putting one and one together and saying, hey, this is indicative of a bigger problem. And then this concept of a fifth vital sign in 1999. And it just kind of kept going up and up and up from that. And the problem is not just at the level of the individual. It seems easy to condemn the individual without really looking that this is a much larger problem. And when I started giving the talk, this was not something that we discussed. This is not something that we recognized. But these companies and many more have paid millions and millions in fines for various practices related to the opioid crisis. Now, why is this? Why do we have this problem among anesthesiologists? The truth is we don't know. There's some risk factors. Many of these are general, and many of these are actually not specific to anesthesiologists, but are risk factors that physicians face. General parental histories, child abuse, obviously the presence of other mental health disorders, childhood drug experimentation, peer workers, all doctors, long hours. We'll get in a little bit more to self-medication. And obviously litigation. As Daryl and I were talking last night, my wife went through a lawsuit several years ago, and, the impact that it had on both of us was just absolutely tremendous. And then in anesthesia, we know we directly handle these drugs. We're exposed to them every single day. We work in a high stress environment. Our hours are variable. We're often isolated. We practice alone. And then we observe the good effects of these drugs. How often do we say to our patients, oh, I have the good stuff. This will make you feel better. Here's the happy medicine. Not recognizing maybe what are we saying to the patients and what message are they receiving? Other factors, physicians over 50% experience burnout, high rates of depression, obviously fatigue. Over 80% of us are involved in an unanticipated adverse outcome or death. And 20% never recover from a catastrophe. You know, and it's interesting, when we think of catastrophes, we think of a patient death or a significant permanent injury. I still wake up today thinking about a near miss that I had years ago. Patient was never doing no harm, no foul. What about the harm to the healthcare provider? And I will wake up in the middle of the night thinking about this particular event. How does death by suicide among our colleagues impact us? And we have a high rate of suicidal ideation. Well, self-medication. And this is an older study here, but it showed that 50% of residents self-medicated. Rather than establishing that patient-physician relationship, they self-medicated. Now, this is an older study, and when I was in medical school, man, the family practice docs, you went to the pantry there in their office, and there was all kinds of stuff available. You know, the kind thing is they could give medications that they prescribed to their patients right there in the office. You know, and you didn't have the insurance or the money, they could take care of you. You know, but only 1 in 4 of these individuals in the study actually had a doctor-patient relationship. And over time, you tended to self-medicate more, not less. And it's all kinds of medications. You know, some seem, you know, benign, like antibiotics, allergy medications, GI medications, but psychotropic and even cardiovascular medications. And what are we missing? Several years ago, I was really having a boatload of anxiety. And I just felt wired. And I went up to all these people and we're talking about it. You know, my program director, Keith Baker, I think I went up to my department chairperson and I said, I am wired and I have all this anxiety. I don't think it was anxiety. I think it turned out to be atrial fibrillation. But because I wasn't going through really that appropriate route and getting the care, I missed something that could have potentially taken my life. It's not just us. Up to 50% of psychiatrists would self-treat for mild or moderate depression. Now, there is some data that shows improvement. We're starting to recognize this, but I still think it's very much part of our practice. 1% to 2% of faculty and residents in anesthesia are addicted to the medications we should be giving to our patients. Death is the presenting factor in 7 to 16%, and maybe even more with relapse. Most recent data, 19%. Among those individuals that survive a diagnosis of substance use disorders in residency and continue practicing, 40% at least will relapse, and 1 in 5 will die. And data done around 10 years ago showed that unfortunately the problem is not going down. It's actually continues to go up. There was a little drop in the late 1990s. This is when I went into anesthesia. We don't know why. One of the suggestions was there was a lot of international medical graduates, and for whatever reason, they seem to have a lower rate of substance use disorders, at least in this study. Alexander's study is really, it was 24 years ago, but it's really the best study done out there, that we have an increased risk of death from suicide, drugs, and other external causes when you compare us with internists. And when we started our drug testing program, one of the arguments was, well, Mike, I've not had a problem for 5, 10, 15, 20, 25 years. I'm never going to have a problem. But it's not true. Even though the highest rate of death is within the first 5 years after medical school, it never goes to 0. You know, we often think, well, things are going to get better when I finish residency. And unfortunately, it's not true. I get calls at two phases of my careers from people. One is 6 months after finishing the fellowship. And people come to me and they say, Mike, I'm not getting the money. The hours are a lot longer. These cases are really tough. And you know what? He goes, I have interesting cases and nobody cares. Nobody wants to talk with me. And they're missing a lot of the great things that Mass General had. We have a group of anesthesiologists that are very tight with each other. I mean, we're talking all the time. If you have an interesting case, every one of us is going to walk into that room at some point or another. You often go in other practices, you don't necessarily have that. I know you have that here at Stanford, but those of you that leave, you might not experience. And, I kind of talk them down and everything and get them through, but sometimes they need to make career changes. And then the next phase is age 45. Man, that's a regular one. I get that all the time. And what that is people coming to me saying, Mike, I've been out in private practice. I don't know if I can schlep propofol, fentanyl, and Versed for the next years of my life. And then I talk them, talk about, look, how their focus has changed a little bit. And most of them stay wherever they're at, but some of them have to make career changes. We make up around 5% of physicians in recovery, but 10 to maybe 20% of those in recovery programs. So a much higher rate. We're more likely to enter treatment for opioids, mostly IV, as opposed to alcohol for other physicians. And 30% of those that end up in recovery programs have a prior history of substance use disorders. The incidence of propofol abuse is going up. Again, this is Wishmeyer study's a little bit old. My guess is that, it's far higher, the incidence of opioids that programs have had, but it had a death rate of nearly 20%. Those that do abuse propofol are more likely to be female, work in the OR, and obviously trained in anesthesia. And there is an association between the lack of control at the time of misuse and the incidence of abuse. Programs that did not control propofol had a higher incidence of diversion and personal use. Volatile agents, very similar to propofol, very poor control. If I asked my anesthesia tech to bring me a bottle of sevoflurane, I don't know if he grabbed 2 of them and just gave me 1. A high rate of death and a very low rate of returning to the practice of anesthesia. I don't read Men's Health, but this was an article written several years ago. It was actually a very well-written article. The one thing I agree with this article, though, is that most at risk seem to be the best in the business. Often young, ambitious, highly talented physicians. The individual you suspect would never have a problem can very much be the one with the problem. And someone one time said to me, Mike, you need to be careful. People don't know what goes on in medicine. Yeah, but when you see this on the cover of the New Republic, there's no doubt what we're seeing there and what society sees. And I worry sometimes we consider substance use disorders among physicians as a hamartia or a tragic flaw of the hero or the heroine. Noah Riley, Carter, and ER of actually a very good representation of an impaired physician. Nurse Jackie, a major storyline, wonderful, very good, caring nurse, but it was part of her persona. House is just crazy. And then right in the middle, the first episode of Mercy Street, Civil War drama. Actually, very, very good show. I think it was, PBS. It shows the main surgeon taking opioids. And I did a debate one time and someone said, Mike, he goes, there's never been a patient injured by an impaired healthcare provider. And it's just not true. And this is, I haven't updated this data in a little bit while here, but over 30,000 individuals have been impacted or potentially infected by impaired healthcare providers. Injecting solution from a contaminated syringe. It's not a new problem. You know, as I say, I doubt the American Journal of Insanity exists anymore. If it does, it's probably paid for publication online. But 10 to 20% of physicians are intemperate. If you look at alcohol today and drugs, what's the incidence? 10 to 20%. One day, the DEA. When the DEA comes to visit, does several things. It obtains subpoenas to check records, does audits, and it does lots of interviews. And they came to visit us one day. And it was because 16,000 pills had been diverted by a couple of nurses over several years. And they found that pill discrepancies totaled more than 20,000. Once they came, they also found evidence of multiple additional nurses diverting multiple substances over the years. And again, these were not operating, these were not, CRNAs. These were practicing nurses on the floor. And look at all the medications they were diverting. And they also look at the Department of Anesthesia. We had Bluebell carts that were unlocked with drugs prepared for subsequent cases. Trainees were taking drugs off campus to conference or to lunch. Syringes of drugs were opened and found in the OR. It seems benign. What you do is you set up your meds, you're ready to go, they're not secured, you go out to see the patient, someone comes in behind you, injects themselves with those medications, fills the syringe up with saline, and all of a sudden you have a contaminated syringe, don't even know it. And there was a deceased anesthesiologist that had diverted some drugs to home. We paid $2.3 million, which at the time was the largest fine in DEA history, to a hospital for lax control practices. And since then, we've been displaced. The University of Michigan paid 4.3, and others are even paying more now. The DEA is realizing this is a cash cow. So does anything work? Reporting, surveillance, education, and control. Well, this is a great study. This is done by Eric Campbell. And it simply asks, physicians should report all instances of significantly impaired or incompetent colleagues to their professional society, hospital, clinic, or relevant authority. Only 2/3, 64%, agreed with that simple statement, saying that we should police ourselves. We should police our colleagues. And that's looking for things. What do we see in our colleagues? What has been, our experience too? Performance goes down, very subjective, arriving late for work. Other things, asking for extra shifts or late calls. Look, I work hard, but I don't want to stay late if I can avoid it. People work alone or offer to give lots of breaks. I don't need, just go take another break. Go take another break. Well, no, I honestly don't need another break. No, I'll get you out. I'll get you out. Sometimes that becomes a little suspicious. Poor drug accounting, difficulty locating on call. Strange prescription patterns. I've joined everybody else. I kind of give the same amount of narcotics to almost everybody. But once you're starting to check out other substances, I'm sure there's somebody out there still using sufentanil, but they're standing out from everybody else. Poor judgment, anxiety, chronic career paths. I always tell when residents come to me and they're interviewing for a job at Mass General, I say, look, one of the things that, for their first job is, look, your first job, that's a free job. And the good thing is, if you end up leaving in 6 months, a year, a couple of years, nobody really questions it that much. Life changes things, better jobs. Maybe you just wanted a little more refinement before you left. But once you start to see changing jobs 2, maybe 3 times, especially early in the career, you start asking questions a little bit. And then personal problems. And as Daryl and I were talking last night, we very much separate professional from personal issues. And we often don't address when our colleague is experiencing a personal life stress or marital problems, financial problems, family dysfunction, isolation. I developed a health problem a couple of years ago. And My chairperson was in my office within, it had to be 1 to 2 days of hearing that I had a problem. And he didn't want to violate my confidentiality. He didn't want to say, Mike, this, and this, but I knew what he was getting at. So I told him what was going on, and he immediately, hey, Mike, I want you to take a little bit of time off. I want you to just, I said, look, Shane, I said, that will hurt me more taking time off work. But yeah, can I cut back my schedule a little bit, take on a few other projects, until I, kind of get this under control. He was very open to it. And I really appreciate that. I have so much loyalty to him today for helping me out that, it makes it tough to even think about going somewhere else. But why do we not report it? Well, someone else is taking care of the problem. Nothing's going to happen. We worry about retribution, not my responsibility. I don't want them punished. Or I believe it can happen to me. And if it happens to me, I can control it. So certainly this individual can control it. But it's just not true. Yet currently our system relies almost entirely upon self-regulation. And we've tried to increase education. And most programs require some sort of education on physician health, substance use disorders, diversion. But we often give it to the residents, but then neglect fellows and continuing education for our faculty members. Yet our systems are changing. This was some good work by Rich Epstein. He was at Jefferson and now he's down at Miami. Just visited him a few months ago. And he did some great work on, probably the initial work on surveillance of records. And they used a couple index cases of substance use disorders. And they went back and looked at the patterns the individuals were exhibiting in their administration of medications. And what they found was there were identifiers that said very early on, there's a problem. And what they identified was late Pyxis transactions. If you're checking drugs out well after your shift, it doesn't make sense. And I always say, you know what? If Fitzsimons goes up to OB, you don't need more narcotics. You might need ECMO. But I shouldn't be checking drugs up on OB. But unless we look for that, we're not going to find those patterns. Now, there are some challenges with surveillance. Discrepancies, occur in maybe up to 15% of transactions. Errors occur at times of entry into the anesthesia information management systems or at wastage. But machine learning can find transactions consistent with a high rate of diversion nearly 6 months before our traditional means. Substance wastage. We waste up to 50% of the substances. That's 50% of morphine, propofol, midazolam, and a lot of this data actually, and I mean the medical system. But unfortunately, controlled substances are frequently diverted from these disposal systems. The Mayo Clinic has a great video that they obtained of an individual basically shaking one of the boxes, trying to get this empty or quote, empty vials of opioids out of it. So additional measures that places are doing, creation of drug diversion teams, obviously the mandatory training, doing external audits to make sure we're in compliance with control of these substances. And then more and more are implementing drug, Pyxis, Shore Meds. Personally, I miss the pharmacy because I think the pharmacist played a huge role in identifying problems. Well, let's talk a little bit about drug testing. So more and more programs are resorting to drug testing based upon the evidence that our prior efforts are just not working. So you can see this is Dr. Zapel here. And Dr. Zapel came to me in the early 2000s and he said, Mike, I want to start drug testing. I love Dr. Zapel. He was wonderful, but I knew he had no clue about how to do this. I think he felt you could just send someone down to the lab, have it done, and you're good to go. And I knew there was a lot more involved in that. And Dr. Zapel knew, that I had experience through the NCAA, being a flight surgeon, being a general medical officer, that I kind of had grown up with drug testing. So we started to do some investigation. A great study out of the US Postal Service, they actually did drug testing on all applicants. They hired most of them. 10% tested positive for drugs. And they hired them all. And what they found over time is that those individuals that tested positive had higher rates of absenteeism, turnovers, employee assistance program referrals, and health benefit claims. It was expensive. $100 million over 10 years would have been saved by not hiring these individuals. Our program costs around $80,000 a year. It's probably a little bit more than that. I don't know. I did this for a paper I wrote a few years ago. But I estimate it costs $500,000 to return an individual to unrestricted practice after a diagnosis of substance use disorders. Detox, assessment, inpatient treatment that's often recommended now for IV opioids, 3 months. Outpatient treatment, and then finally psychiatry contracts, testing, legal, lost revenue, replacement physician or nurse anesthetist. It's not cheap. The Federal Railroad Administration, they had a 5% incidence of drug presence during accidents before testing. It went down to 1% afterwards. Now, testing has been done in medicine before. Random has never been done. But studies showed a couple things. One is people will test positive, including residents who are starting the first day of a career that they've spent hundreds of thousands of dollars preparing for. 2, the incidence of positive drug tests goes down when sanctions are implemented for positive results. And last, the rate has decreased since testing again has been coupled with refusing to hire. So we started our program back in 2003. It wasn't just drug testing. I insisted that it is not just drug testing, that we needed to enhance education. We would implement drug testing. And over time, we developed enhanced control measures. We had about a 1% incidence prior to 2003, no higher, but certainly no lower, and a 2.2% after. 2.2% incidence among CA1, the early residents, just what the data shows. And we had a 0% incidence in the first few years of this study. And we've gone back and published our results again. And, we feel that we've seen a statistically significant reduction, but a larger scale study is needed to really prove whether this is beneficial. So I really think that a large scale study, and as we get more and more programs that are thinking about this, I think it's feasible to do it. But we always need to think about, is this dangerous? How do we deal with results? Well, drug tests can be positive in healthcare providers, for lots of reasons. The two that are really important are the presence of a substance use disorder and the presence of a substance use disorder plus diversion. But I have in green here appropriate treatment. One of the things that I 100% believe in and that we need to convince everyone of is that a treated physician, appropriately treated with a doctor-patient relationship, is far better than an untreated physician or a physician treated through inappropriate routes. And we do trust that the physician patient, and the physician treating them understand the impact of substances that they are prescribing. Our program is set up, if you end up taking a certain medication, but you have a prescription, the drug test is reported as a negative result. Because we want people to feel that they need to get the treatment they need. But there are other things that we need to sort out. There's a possibility of dietary consumption. Things can be contaminated. Well, I just smoked some marijuana last night. That's all it was. Well, all kinds of things are being added to marijuana now. We've had cases where somebody obtained a medicine that they've previously had prescriptions for through an alternative route. And we sort it out and we go through and we work with them and their physician. We figure, yeah, you know what? Okay, this is legitimate, but the future, you need to do this, you need to do this. If you don't do it, we're really going to have a problem. Intentional poisoning, drugs of date rape. So all of these need to be considered as potential possibilities. You can't just take the result blindly. Early studies, what they showed is often drug tests came back positive. But then once they sorted them out, they found lots of legitimate reasons that someone would be on a medication. The ELISA test, the dipsticks can be positive. But a good program rules this out by following up with gas chromatography mass spectroscopy to eliminate these false positives from ELISA. But we feel an obligation to report our results to people. And this was a case that we had of what we called it a false positive result, but really what it was the way the system is supposed to work. The initial ELISA on my colleague said ketamine. The gas chromatography said indeterminate. But fortunately, we always obtain 2 specimens, send one to the initial outside certified lab. If there's any question, we have that second one available that in conjunction with the physician we're doing the test on, we decide which lab should we send it to. And we sent it to another lab, and that other lab said, no, there's no problem with this. We got our colleague back to work. So again, the results need to be scrutinized. Is it easy to beat? Well, these drugs don't last forever. Usually 24 to maybe 72 hours. Marijuana can hang around for reports up to 72 days. Now that's probably if you're Snoop Dogg or Willie. But marijuana is lipid soluble. It can hang around. People try and adulterate these. If you go on beatdrugtest.com, all kinds of stuff pops up. I like the marketing departments too. The urinator, urine luck. That's a creative one. But just like there are scientists on the internet, there are actually legitimate scientists that have determined ways to detect if a sample has been adulterated. And if you're willing to risk your career on someone that's going to sell their urine online, you might have what's coming to you. So here's a couple things about drug screening. It does not determine abuse, misuse, or dependence, only the presence of a substance in urine. All results must be investigated even after a medical review officer confirms the result. Urine screening is only one component, and a large-scale study is necessary. The good thing is we're as likely as any other specialty to return to our practice or maintain sobriety for at least 5 years in good treatment programs. Now, this study was very limited in the fact that only 16 of 48 physicians' health programs actually participated. 70% of individuals remained clean, 20% relapsed 5 years in the best programs, and 2 to 3% died. Now, this is, as we finish up the next few minutes here, I think this is one of the things that I'm most proud of. And I think this is one of the most important and impactful things that you can actually do. And this is an intervention. We've performed multiple interventions on colleagues over the 20 years of our program. And we believe this is a key component to assist our colleagues. And it should be done without a foregone conclusion. Now, interventions need to be done and adhere to the four principles of bioethics: autonomy, non-maleficence, beneficence, and justice. Now, what has caused us to do, or what are the reasons that we do an intervention? They fall under almost all of the six core clinical, or five of the six core clinical competencies. The one it doesn't really fall under is medical knowledge. We don't do an intervention because someone scores poorly on the boards. But, things that people, arriving late while on duty or on call, dishonesty, calling in late, calling in sick or late very frequently, beyond anything that could be normal, just the abnormal behavior. And this is what I tell my residents all the time when they're putting a line in. I said, when you're putting a line in, I don't care if you know what's wrong, but it is imperative that you know when something is not right. And I think that's an important point. Is that's gestalt. And someone says to me, well, Mike, what if you're wrong? It's very easy. Never wrong. Because of the fact that you're never wrong to be concerned about a colleague. Now, we've had multiple interventions that have not, in fact, the vast, vast, vast majority of interventions are not substance use disorders, but there's still an issue we need to deal with. But the substance use disorder is the thing that can kill an individual. So we rule that out, but then we also address the other factors. And sometimes it's just as simple as you need a smack on the hand. You know what? You gotta get 2 alarm clocks. You gotta show up, okay? You know what? Everybody else is showing up at 6:30 to set their room up. When you're coming in at 7:10, that's not right. But other times we've encountered health problems. We've encountered family problems. And we need to deal with those. So what are the components of a good professional intervention? And there's a lot of them right here. But, just to quickly summarize, you got to act early. Understand there's uncertainty. You don't necessarily know what the problem is. Due process and timeliness. If you're doing the intervention 6 months after a problem, that's not very timely. Privacy and consistency. We do it the exact same way every single time. We'll meet with a colleague. I'm generally always there. I think maybe once I was out of town. We always have another person, either the vice chair or our vice chair for education, or our clinical vice chair, or the head CRNA if we're meeting with the CRNA. And we always have a psychiatrist. Every single time we have our psychiatrist. I've worked with him for 20 years. Just text him. I'll text him, hey, John, need to talk to you. All right, Mike, let me know. If John can't do it, we find somebody else. I remember I had to do an intervention once, and John wasn't available, and he sent an individual that was from another country. And it turns out that individual was from the same country of somewhere we were doing an intervention on. And I thought, oh my God, how great is this? And all of a sudden, I just remember looking at, doing the intervention, and all of a sudden there's this sense of relief that came over them, because it turns out inadvertently we were culturally sensitive to it. And it wasn't a substance use disorder, but, it was something which we needed to intervene on. Maintain the dignity of the individual and have mental health support available. You need to be sincerely caring and concerned about the colleague. You're honest, but you maintain their confidentiality. Security. From the time, once we do the drug test, or once we do our intervention, we go over, we get a drug test, and we do remove them from clinical duty and remove their ability to get substances from the operating room. It is not an administrative leave of absence. It is a medical leave of absence. It's gratis. It's their time. Some people need to meet with family members. Some need, some might need to meet with a psychiatrist or a psychologist. Some just need the time to get things in order. Continuing support and follow-up during, while you're waiting for the result, and afterwards. And then the last one is moving on. Once we are happy that we've resolved the issue, it's time to move on. Now, I want to give time for some questions here. So substance use disorders is only one component of impairment in anesthesia providers. Unfortunately, anesthesia providers continue to die yearly from substance use disorders and death by suicide. And we need to do something to reduce these problems. But there's hope for providers, those that are impaired by substances and those that are impaired by other problems. I am a 100% believer in zero tolerance. And what that means is we can't tolerate colleagues that are impaired or using substances. But I do not believe in one strike and you're necessarily out. Every case needs to be approached on an individual case-by-case basis. Return is legitimate course for some individuals, but for others, the more compassionate and safe thing may be redirection into another specialty or potentially another career. Drug testing is mandatory in most lay industries and is mandatory in federal agencies tasked with the safety of the public. Comprehensive drug testing is a part of the safety culture in aviation and ground transportation. You know, as I end here, I always like to say, you know, every day we carry the precious cargo of our family, our patients in our hands. And it is critical that we are unencumbered by any form of impairment. You know, these are my, you know, my daughters here, Caitlin and Annabelle, the 6 girls there, my mom and dad's 6 granddaughters. You don't see my wife there. Like taking her picture is like getting a gremlin wet, or feeding them after midnight. You just don't do it. Anyway, thank you very much. And I'd love to take questions.
Awesome. Thanks a ton, Mike. We have a few questions on Zoom. Are there any questions from the live audience? Javier to the left. Javier, please.
Use disorder. Often they're both very emotional. Peer review when student case review and decision making, clinical outcomes.
No.
Is there a substance use here? So I wonder if you can share.
So our program is, we really separate safety and clinical competency. You know, one doesn't trigger an immediate event with the other. You know, sometimes people will bring up an issue. Hey, could this be a substance use disorder? And if they bring that up and they're asking the question, then they may bring it to me. But it is definitely not an automatic referral there, because, you know, I think that, you know, these things unfortunately happen enough in medicine that we could kind of overburden the system. But I think you could also create fear, you know, especially with safety and quality. You know, we need to do as much as we can to maintain the openness and the willingness for individuals to participate. And not only, you know, there may be the individuals themselves that need to participate, but we also have the individuals that sit on those committees. And we don't want them to be fearful of, well, is so-and-so going to be referred for this if we address this particular problem, or I raise this issue. I think I want safety and quality to be as open and a safe, you know, venue as possible. So occasionally they will, you know, overlap, but for the most part, we do try, and we don't have an automatic referral system at all. No. Does that answer your question?
I do have some particular question that you might have 30 minutes this morning, so I'm going to say some questions.
That sounds good. I look forward to it. Ron.
If you do identify someone with substance use,
So fortunately, we have the safe haven of physicians' health programs, and they can get to physicians' health program as long as there's been no, illegal activity and that there's not been any patient harm. That is a safe haven that they can go to. Physicians' health programs, you do not have one in California, but they serve as kind of case managers, not treatment, but case managers for individuals with substance use disorders. And they often have agreements with the state medical boards that we can manage this, but that patients that physicians need to be reported under certain circumstances, though. Yeah.
We don't have a PHP in California.
Mm.
Currently, our hospital serve some of those
Yeah.
functions,
Mm.
and so that's why it's an important committee in the hospital.
Yeah, and that it's not the end of the world. As long as they adhere to the good principles. I think very good physicians' health programs do absolutely wonderful jobs and everything. But a lot of them, a lot of them chose not to participate in that early study because they didn't feel they had the appropriate funding, the appropriate resources, to really have the optimal outcomes. But I am actually a very big fan of physicians' health programs, but certainly what they can do can be replicated. And I imagine that your physician's health status committee or whatever they call it is actually very good.
Marianne, I'm just after your question, I'm going to repeat it for the folks at home.
Thank you so much for your talk. You had mentioned early testing program that you had curious what the policy at the department is about.
Mm. That was data prior to data prior to drug testing that we had. So prior to implementing the program, we had a 1% among all residents. And I think that was 10 years of data prior, and a 2.2% of CA1 residents, but that was prior to us actually implementing the drug testing. Since then, we've had what we feel is a 0% rate among our residents. It does not mean that we're maybe capturing everybody. We may be missing out on people, okay? But at least the system afterwards, we feel that we have a 0% rate. As far as residents returning back, I still believe in a case-by-case basis. The concern about residents is studies have shown 40 to maybe 60% relapse rate. And the challenge with the residents is your time risk of being around these drugs is 40 years, maybe more than that. And there's a lot of stressful factors that go in. And when you put all of that on, obviously, a history of substance use disorders, it does become a very, very big risk. The data that has come out of physicians' health programs, they actually have a very small number of residents and really haven't, from their standpoint, been able to make a very good conclusion. But I really worry about the time risk associated with residents. It's a long time. And you have, during your career, you have health problems, there's can be legal problems, there's marriage, there's divorce, there's kids, there's job challenges, lots of other stressors come on. So I feel you need to be really, really careful with returning a resident because you're subjecting them to 40 plus years.
Very robust online question. So one question, which I know you have a few opinions about, is what is your opinion about cannabis usage?
Very, very good question. I mean, I have my personal opinion, and then I kind of have the scientific or the things are said is. Personally, I think it's more of a dangerous drug than we actually recognize. It's also a very unpredictable drug. What studies have shown is that, among pilots, that we consider ourselves the pilots of the medical system, or certainly the pilots of the operating or the fighter pilots. And marijuana can cause impairment 12, maybe even up to 24 hours afterwards among pilots in simulated environments, and they're not often aware of the impact. The other thing is a lot of studies have been done years ago when the THC was far lower in potency than it actually is today. Aviation data shows an increased rate of the presence of THC on autopsy studies. So what we do in our system is we do not test for marijuana pre-employment. We do not test random. We do test for cause though. And the honest truth is, if your performance is or your behavior or whatever is impaired and marijuana is present, it's a tough argument to say it's not the marijuana that's actually speaking. And now a lot of states have prohibited testing for marijuana for everybody because it's legal, but other states have done what I think is the right thing to do, is actually allow testing and prohibit being under the influence of marijuana or the presence of cannabis in those specialties that are or in those careers that are tasked with the safety of the public, those that work around children, those that work with the elderly, those that have the safety of the public in their hand. And I think that's the absolute right way to go.
Thanks. And another question from online. This will be the last question, is for the folks who do test and have a test that is later determined to be a false positive, has anyone studied the impact of that experience on their mental well-being and stress, given that how that goes down?
Absolutely great. So remember, on some of these, you will have, we've only had a couple that we would say, yeah, these, I would consider this a quote false positive result. One of them was that we had set our threshold for testing for opioids far, far, far too low. Okay. So we actually moved it back to the federal level. Okay. And so we think our threshold was just too low at the time. And then another one was that one that we reported there that really wasn't a false positive. It was more just the way the system is supposed to do it. But to honestly answer your question, we have not studied that. But I would say for a lot of people that we've had to do interventions on for other things, for interventions associated with this, a lot of them come to me for letters of recommendation or come to me for advice about how they run a program at their own institution, or, I think the relationships remain pretty good, but also a couple of them have told me, they're still kind of mad about it. But at the same point, they call me up as a friend to chat and talk and, and like that. So no, we haven't studied, and we definitely considered it, but we haven't done it though. Yeah. Mm-hmm.
Awesome. Thanks everyone. For the folks who are live, I'm sure Mike will be happy to answer some more questions up front. And for the rest, wishing you all a great day and a great week.